Great, thank you. It is my honor to introduce Dr. Katherine Berg, who will be speaking in our final section this afternoon on rehabilitation care delivery in long-term care settings, key research findings. Dr. Katherine Berg is the chair and associate professor of the Department of Physical Therapy, the executive chair of the Rehabilitation Sciences sector, and the chair of the Graduate Department of Rehabilitation Sciences at the Faculty of Medicine, University of Toronto. She is also a fellow with InterRI, an international team of academics, clinicians, and other professionals committed to developing and using standardized assessments to improve the quality of care. Dr. Berg's area of clinical expertise is in geriatrics. Her thesis work involved the development and validation of a balance scale widely used in rehabilitation and geriatrics. Her research interests include disability and fall prevention, as well as health services research, examining quality of care and outcomes following post-acute interventions. Thank you.
Thank you. So it's my pleasure to be here today. I'm shorter than the others, so I have to. And it's my pleasure that I'm presenting on this panel because I think physical activity is really important, and also important that we look at who's getting these services in long-term care. I'm not sure I have all the answers, but I actually had fun going through some literature that I actually wasn't aware of, or some more recent literature that was fun. And so thought I'd just start with just reviewing what some of the approaches are with OTs and PTs. And I find that many can't distinguish us and just wonder what we do. Thinking about setting goals, models of delivery, I really browse the literature, finding some areas of evidence to try to make this coherent. But I think the most fun we'll have is at the end when we discuss what can we actually do and how do we move forward with this and incorporate sort of both targeted physical activity and targeted physical therapy and physical activity, because I think we all have to work together and figure out how we manage this in long-term care. So occupational therapy. So I'm a physical therapist. My apologies to all the OTs if I get this wrong. I know that enabling occupation is the key area. And I think both of us start with the concept of function. What can the person do for themselves? And the OTs then tend to look at adapting the environment, modifying the task. They sort of analyze the movement, break it up, to try to improve the person's participation in activities of daily living, particularly those that are meaningful to the person. I did pass this by some OT, so it passed a couple of tests, though. And for physical therapists, that's my profession, and I think we are trained to really analyze and measure movement and function. So we can diagnose movement disorders, and by that I can speak quite generically. Why can't somebody lift their arm over their head? Not just that we're looking at perhaps bringing to the attention of others some perhaps potential neurological conditions. And then when we look at how somebody is moving, then we try to determine what are the factors constraining those movements. And that could be strength, it could be balance, it could be range of motion, it just could be fatigue. And we're trying, our expertise in trying to determine which of those factors can we improve and which will have to be adapted for, and that we can perhaps maintain. But then after that, we also have to develop exercise programs and practice opportunities, because just strengthening those factors does not necessarily mean they'll be brought into and used by the person in their activities of daily living. So that's really where our expertise lies. And, looking at exercise programs and practice opportunities, that means that others have to be involved. And so particularly if you have some cognitive impairment, that has to be the whole team trying to create those opportunities for practice to, that perhaps we can give the expertise of what to emphasize in that practice, under what conditions, but it really looks at how do we, all become involved with try to practice, and that really does fit with the physical activity and move it philosophy. We're also involved in pain management, non-pharmacologic pain management, either sometimes just exercise, positioning, relaxation, or it could be some TENS or hot packs, etc. Wound care, people often forget about us in wound care in terms of ultraviolet or laser can actually heal, promote healing. Incontinence. Now, incontinence we can impact through improving mobility or working with people with scheduled toileting, but there are pelvic floor exercises. I would think for cognitively impaired that would be really tough. And I know that with patients with stroke, there's some evidence that we can improve that, but so I'm not sure that's a main emphasis in long-term care. Consultation to staff and family, positioning body mechanics to present injuries. Now, if somebody's about to go home, you need to be practicing with the family, even if it's out for the day, or with staff. So I think, it's not always patient outcomes. I like to think that hopefully staff are coming and saying, you know what, my back is killing me when I'm moving this person. Can you work with me? So I think that's a valid goal as well, to engage the physical therapist. So again, just the message is P and OT are not interchangeable, but share some of the features. And I think we both start with function, but with the direction we take after that. And of course, with most of these people, there's enough room for everybody to be involved. I think it's really important that physical therapists, and I don't see this happening in long-term care some of the time, that we're actually setting goals with the whole team. Physios are often, we teach our students to do SMART goals. And so you end up going, well, can the person walk 10 feet in a certain time frame or whatever? That might be a smart short-term goal, but that has to fit within something that's meaningful to the person, the family, or the staff. So, there really has to be bigger goals. Okay, so that's kind of setting the stage for what we do and how we probably should be interacting. So then I went back and thought, okay, so of the factors that we know are commonly interfering with a person's ability to function independently or move about independently or at any stage and in any range of some degree of independence, common ones are strength, range of motion, balance, endurance. So the seminal strength study that I'm sure everybody's aware of is Maria Fiataroni's work in 1994, published in the New England Journal of Medicine, which in medicine is like the top of the line. And basically, this study showed it was a randomized trial, and they had 4 groups. So progressive resistance strength training, micronutrient supplementation, a combination of the 2 of them, and neither. And her results, and she looked at 100 frail elderly. So no excuses. These people were in nursing home and they were frail and they were on average 87 years old. She managed to get 94% of them to complete the study, which is quite amazing. And really, strength increased dramatically in the exercise groups. She also noted increased gait velocity in exercise groups and decline in others. And, gait velocity is sometimes a marker of frailty. So, it's beyond, you're looking at gait velocity, but it may be meaning more. Greater stair climbing power in the exercise groups. And the micronutrient supplementation without exercise had no effect on strength or weakness. So you really have to be exercising. And, she was very deliberate about really exercising enough. This is another study in 2013 that looked at the systematic review. Again, in long-term care facilities, 12 studies, over 1,000 participants overall. Now, I'm mentioning this because overall exercise in this study, systematic review, showed that exercise prevented falls. But you got a greater benefit, so the relative risk doesn't change tremendously, but the confidence interval gets smaller. If you had 2 types of exercise, so balance and resistive training. If you had 1 to 3 months or greater than 6 months, so again, the confidence interval gets smaller. Frequency at least 2 to 3 times a week. you're getting slightly more of an impact. So just to show that, we really do have to be looking at longer time frames and have enough in the syringe to make a difference. This is another study I'm highlighting. Again, it's the impact of the individually tailored physical and daily activities. Again, a randomized control trial. So, it's not, if you want to make a difference, you have to make sure that you're tailoring the exercise or the intervention to what you want. So this intervention had about 300 people, and they were reassessed at 3 months. The intervention group received tailored physical and daily activities. The control group had ordinary care. They had significant differences in balance, physical activity, and transfers. And actually, the control group decreased in balance, ADL, and transfers, which is, there's a proportion of nursing home residents who are declining. So having the intervention can be looked to slow that decline. The intervention group also improved mobility speed in either walking or wheelchair speed. And, wheelchair, getting around, that's a viable method of locomotion and, helps maintain that person's independence and a consideration of, what they can do for themselves. And there was greater improvement if they had more than 150 minutes per week and participated for more than 10 weeks. So it was a 3-month intervention. So I guess some people dropped out earlier somewhat, but if they stayed for at least 10 weeks, they showed greater improvement. Now, Kathy Roach from Miami, she's a physical therapist. I was pleased to find this study from a couple of years ago, and they focused their study for Alzheimer's disease. So because that's often what I hear. Oh, well, I can't give physical therapy to people with cognitive impairment or dementia because they're not going to improve and they can't follow my instructions, and et cetera. Well, she looked at 7 long-term care residents, 82 in total, with mild to severe Alzheimer's, and did a 16-week progressive program, and had the people sort of face-to-face doing knee bends, going up on toes. So it was, pretty common exercises that you could do with someone else, sitting, pushing, and pulling to try to get trunk strength. And the rationale for her choice of exercises, well, what was important for sit to stand and mobility. And then also there was a balance component of, again, walking sideways, turning, making a circle. And if you're going to want to improve balance, you do have to make sure you're challenging the base of support and getting people to function at the edges of the base of support. And then there was also a supervised walking practice where they're sitting, they're chatting, walking, and gradually progressing that. So in all of these, they progressed the repetitions, etc. So the control group, she had 2 of them. One was a supervised walking program. Again, they walked and they walked and talked with them, and gradually increased the time. And they could use whatever walking aids they needed. And then another attention control group. So the activity-specific exercise group improved in transfers. And they used sorry, I forget the name of the scale, but anyway, there were a number of transfer items and they improved. The other 2 groups declined. So you can do it. You can get these folks to improve. And the greater effect, not perhaps surprisingly, is the subgroup who were more impaired or very low mobility at baseline showed the greatest improvement. The critical components, as they emphasized also, is a concrete structure, repetition, so you have to get enough practice, and familiarity with the equipment, sequencing, and the training personnel. This was another study in residential care facilities, again, functional exercise program. Again, half of them had dementia, so they included people with an MMSE of 10 or more, so 10 is pretty low. And they did high-intensity functional weight-bearing exercises, 29 sessions over 3 months. Significant improvement in ADL. but no difference at 6 months, suggesting the need for continuous training. And I'm not saying that continuous training has to be PT, but that's where we really have to think about how do we marry programs of physical activity and that culture of physical activity to try to keep up the gains. And I don't even think that you need physio for 3 months. You know, you need to be setting a plan, and then I think that's what we're all struggling with is how much of one-to-one or specialized group do you need, and at what point can others take over? So I think those are questions we haven't answered. And this is just an exercise in social activity, just reinforcing what you had said, that high intensity 5 days a week for 7 weeks, and the exercise and social activities groups improved. The usual care and social activities group both declined. So, you know, we want to do this fun. So what are the ways that signal who needs physical therapy or occupational therapy? You know, you could think of the CAPS. I think we need further work on the CAPS. The newer CAPS are perhaps a bit better, but I still think we probably need to be even more prescriptive in some areas. But several of the CAPS do suggest consultation with PTs and OTs. Just for those of you who are interested, these are sort of the frequency of the CAPS that are triggered in long-term care in 2012. I think my time is coming to an end, so I can't talk too much, but the ADL one is certainly an area where, you know, about 30% of those people improve. So we really should be at least using that partly as a basis. The rehab algorithm that was developed for the community, along with the contact assessment, is another potential. And that really is, you know, a recent change in the person. So a recent decline in function should be signaling that there's probably room for improvement. Or we heard a recent improvement, and that could be anything. They've, you know, become less depressed, or, you know, pain has decreased, and now they're ready to start more. Monitoring outcomes, we can be monitoring, certainly many of the studies I looked at chose different outcome measures, but certainly the inter-eye subscales are available to use for monitoring as to how people are doing. Quality indicators, you know, all our organizations are being monitored for quality indicators, and really, if we're effective in some of these interventions, we should be able to find improvement in quality indicators. So such as preventing ADL decline, you know, managing pain, various indicators. So I think it's important for physical and occupational therapists not just to be sort of coming into a home and leaving, but feeling some sense of commitment that they should be working and helping the organization look better in quality indicators. And also publicly reporting. And I separated those out because there are quality indicators that aren't publicly reported, but that might be beneficial to be looking at in terms of any new programs that homes may be starting. So again, before I leave, want to emphasize, so in balance, and that's a special area of interest of mine, we need to be thinking of challenging, fun, individual, and targeted to interest and ability. I mean, I think sometimes it's a shame that, our long-term care homes sort of have less of us there, because I think it actually takes a bit more skill to be thinking of creative ways to engage persons who don't remember your exercise or instructions from the day before. So structuring practice is even more important, that you get them to improve their balance. But you can be using, I've used golfing activities, that's a weight shifting exercise. If they're old golfers, that's good. So trying to include the fun and challenge. But if you're somebody who can walk, don't think you're doing anything for balance sitting down. You have to be. And if somebody's got decreased endurance, don't do range of motion exercises in sitting while they're there. Do something that's actually going to challenge them and actually improve balance or at least standing up strength. Structured practice. I think that's extremely important to be practicing in creating environments that facilitate practice, and whether those are, those streets, various things, or whether in a room the furniture is arranged more optimally. You're going to drag me off soon. Sufficient intensity and duration is also important. It has to be long enough, and there's enough in the syringe to make a difference. And so these are my challenges: is how best to embed targeted PT programs within a culture of physical activity. What staffing types and levels are optimal? I was having lunch with people today saying we don't have really enough staff. And then that's the question of who's engaged and how do we best involve the PT, the kinesiologist, the PT assistant, everybody on the floor, the floor cleaner, everybody in trying to structure this. How best to engage an interprofessional team in long-term care? I think we're not using telepractice enough. We could be having virtual teams consulting in long-term care. I'd love to have more students in long-term care and me be their telepractice while they present the patient or something. And then what's really important is that we need to signal each other. So a PT needs to signal when perhaps a physician is needed to make a consultation. A PSW needs to be able to signal when, they had a bout of PT, but something's happened, they're just not functioning as well. Perhaps they need another one. So we need to be able to know when to cue for each other. That's it. Those are my challenges. All right. Thanks.
Thank you so much, Dr. Berg.